Hello, everybody. I hope you're enjoying your lunch. My name is Derek Mitchell. I'm the CEO of iPosy, and you're very welcome to this lunchtime discussion on access to health information. So it's being organized by iPosy, and we have a number of panelists and speakers here, and I hope you've had a chance to view the agenda. If there's a possibility of maybe posting the agenda in the chat, I think that will be of use to those who are registered. We have over 120 people who've registered for this event, so there's clearly a good bit of interest. So this event is being organized as part of an iPosy social media campaign around access to health information. We feel it's very timely to be talking about this in Ireland for a number of reasons. One of which is that Ireland is preparing legislation on a health information management system, as well as the rights of individuals to access their own information, which is likely to form part of the new bill. HIQA has a consultation open on draft national standards for health information management in health and social care, and iPosy will be using the discussions from today to inform our submission to that consultation. So that consultation is to include a requirement to process data in accordance with a rights-based approach. So today's event is very much about, well, what does a rights-based approach mean when you talk about access to health information? And this is something that iPosy is taking more of a rights-based approach to a lot of our work and our priority areas. And last but not least, December 10th is International Human Rights Day, so it's incumbent on groups like iPosy to be organizing events in the lead up to this to spread more general awareness about the importance of taking rights-based approaches. So we have a number of speakers here this afternoon, and I'll be introducing them, and we'll be forming our conversation around three main questions. And the contributors are coming from patient and public perspectives. We are also, we're joined by Kerry Lawless. Kerry is one of our iPosy patient graduates of our education program, and has had various regular interactions with various parts of the health system to manage her long-term condition, and she has regularly accessed or requested access to her health information, and she's had to follow a range of administrative processes and has encountered a number of delays in having her requests processed. We're also joined by Mary Visegi, and Mary has a daughter with a rare condition who interacts with over a dozen different ologists to manage her health, and this means that she accumulates a lot of health information. So Mary is conscious that other individuals with this condition also produce a lot of health information, but these pieces of information are not joined up to get a full picture of the rare condition prevalence and indeed presentation in Ireland, or of the individual's current treatment plan, which clinicians often depend on the patient to coordinate. So Mary's currently undertaking a PhD in partnership with Trinity College and Future Neuro to explore the possibility of establishing a patient registry for her daughter's health condition. So it's very much from the patient's side. We're also joined by Brian Macmillan. Brian is a GP in Sheffield in the UK and is a senior clinical lecturer at the University of Manchester. He supports patients having access to their primary care records, the GP record, and believes there are practical solutions to address legitimate healthcare professional concerns about how to record health information when a patient is able to view it, in particular, how to record sensitive health information like mental health or addiction status. Our other two speakers are and I don't see him. Oh, yes. So Kevin O'Carroll. Kevin is the Technical Standards Manager at the Health Information and Quality Authority, HIQA, in Ireland. And HIQA have a health information function, and they have a remit to provide thought leadership in defining the health information landscape in Ireland by using best available evidence and engagement with stakeholders, setting standards and developing guidance for health information, and assessing the compliance of service providers against these national standards. So as I said, HIQA currently have a public consultation, and in addition, they'll be undertaking a national engagement on digital health and social care in 2023. And last but not least is Ruth Davis. So Ruth is a practicing barrister at the Law Library since 2018, involved in civil litigation on a wide variety of areas, including personal injury, medical negligence, and data protection. Ruth has a BSc and a PhD in microbiology, and prior to joining the Law Library, she worked for more than 20 years at senior management level in the Irish health education sector, spanning a wide range of strategic and operation portfolios. She was a member of the HSE's working group that developed the new HSE's Consent for Health Research policy, which reflects the requirements of the new data protection and other health-related legislation. And she was recently appointed by the Minister for Health to be a member of the NREC, the National Research Ethics Committee for Medical Devices. She's also a very passionate member of the Research Committee of Cystinosis Ireland, IPOSI's patient member, which supports advocacy and research into this ultra-rare genetic disease. So I went through that as fast as I could. So we're into the three main questions, and really we're asking everybody to contribute in terms of our panelists to these main questions. And the first question is around, should people be able to access their own health information? And certainly I'm getting the sense from our pre-meeting with our panelists that the answer is very much in the positive. But in terms of that should question, what are the benefits for patients, and are there any risks in terms of people accessing their records? So I might turn to Kerry and Mary first on that particular question. So Kerry, what's your perspective on that, benefits and risks?
In terms of the benefits, there's huge benefits. I've a similar experience to Mary in that I interact with well over 15 different between consultants and GPs and occupational therapists and physiotherapists and different healthcare professionals in acute hospitals, community care situations across the public and private sector. Because I have a long-term health condition, I have a number of disabilities, and I'm also in recovery from breast cancer. So there's different levels. So having to sort of bring around your health records in a series of different folders and sometimes plastic carrier bags is not ideal. So obviously having access to that in a way is of huge benefit, not just to me as a patient, but also to the healthcare professional in front of you, because they don't have access to each other's systems. And sometimes, particularly within our overstretched and underfunded public healthcare system, their own records are far from ideal, and they may not have access to everything that they would need, or it's done in a way that makes it very difficult for them to keep on top of things, and they may waste 20 minutes of your appointment time trying to get themselves up to speed, and rotations change and you don't necessarily see the same doctor that you saw the last time, and it's not best use of their time or your time as a patient. So it would be hugely beneficial if everyone had good access to the system. In terms of risks, I suppose inappropriate access are the right people. Having access to the right records, would people be worried that people would see records that maybe you wouldn't want to see those records? Is there risk of abuse if someone's in a situation where they have a carer, or in case of maybe intimate domestic violence situations, those sort of risks? I'm very much on the I want to know everything about my health. That's what reassures me, particularly when I'm getting bad news about my health. Information is power for me. Not every patient feels that way. So we need to make provision for people who have different attitudes towards their health for people who maybe want to get a little bit of information at a time, and take different approaches to their health. So there needs to be provision for that, that maybe if it's bad news that you're getting, that maybe some people would rather they hear that news through a doctor and through the filter of somebody who can sit and explain that and put that in everyday language for them, and reassure them. And they'd rather that news in a doctor's office, with that care and support around them, and that provision is made for every type of person and every type of patient, because that's what we all have to remember, that all of us are one illness or one accident from being a patient. Patients aren't, different people out there. So we're talking about all of us when we talk about patients and access to medical information. Yeah.
Thank you, Kerry. If I might turn to Mary. So Mary, I think you can complement Kerry's perspective there quite well in terms of what you've been asking patients and maybe family members as part of your work to develop a registry about what maybe information they would like to see. I mean, how does what Kerry's experience has been or views how is that reflecting in your own work?
Very much so. I suppose it's mainly a clinic as opposed to the registry that I was aiming for, where we need this joined up thinking. But I do not think that in this country we will necessarily find all the specialists that each person needs under the same roof, under the same hospital. So this fragmentation of care, of records, of documentation leaves a huge space there for error. And as was pointed out, there's all types of, if you're looking at the process, if you're looking at time, if you're looking at resources and how resources should be used, the way that things are happening right now for patients is just willy-nilly. People also do not get their results in time. They're afraid to book on holidays because they can't get the access. They don't know how to get access to their results. They don't even know that they can. They're told, oh no, we can't give you that result. And they take that as, okay, well, I can't have it. And I think just before the discussion, and I have one of my daughter is in France, and if you could just copy paste what they're doing here, she has an app on her phone. It's easily set up. She controls who can see her data. She controls what she shares with the medical professionals. So she doesn't have to share everything. The only person who has the full access to her care would be her own GP. And it is a situation of an opt-out situation in France. So everybody has this and they can use it or they may decide not to. But it simplifies prescriptions. It simplifies, I think Kerry a few days ago pointed out to us that now the GP sends your prescription to the pharmacy and all of a sudden you turn up. You don't remember that it's been 3 months since the last time and you turn up and they're saying, oh, well, we can't give it to you because you haven't got a prescription. And we're saying, what? So you have to go back to the GP. So that's a simple example. And the patients I'm visiting in my interviews at the moment, it breaks my heart because they, like my daughter, have to see probably, 10, 15. You've got every organ in the body that can be affected, plus the physios and the speech therapists and everybody else that goes with it. And they have no way of coordinating the care, but they can't even coordinate the care because they don't have the information. So they go from one doctor to the next, but they don't have the information to give them. And that doctor hasn't got access to the other hospitals' records. So, medical error in a big way can happen because of the lack of that centralized information. The risks, I see fewer. I think they're outbalanced by the benefits in a huge way, because if you're going to take in patient safety, economics, less stress on the patients, on the system, on the individuals, yes, of course, people can breach. But I think that fades into the distance when we see what can be done when it comes to securing data and when it comes to data protection, whether it be the legislation and everything else that goes with it. For me, yeah, benefit, big way benefit. Sorry, I've chatted for too much.
No, Mary, I think what certainly what I'm taking from your examples is that the clinical risk of not doing this far outweighs any potential risks that are associated with the access point. And I think what's currently going on in England, in the UK, is something that we're watching very closely in terms of the switch on of the GP record for providing prospective access to citizens in England to the GP record. And I'm very glad that Brian has been able to join us today to maybe give us an update on maybe how that has been working or not, as the case may be, and what the experience has been like from maybe a GP's perspective.
Yeah, so it's been in England, it's been in the GP contract since 2019. The GPs in England have to offer and provide patients with access to their record if they request it. So at the minute it is an opt-in process. So currently you do have to ask. Under current GDPR law, if anybody asks for any information that we hold about them, we are legally obliged to give them all of that information. So if one of my patients said, I want access to my entire health record right from when I was born until the current day, I would obviously have to give them that access. What NHS England have been trying to do is to make it the default, so to make it an opt-out process. So you don't have to ask, you just automatically would get access to everything that's in your GP record from a certain date onwards. And the reason they've done it prospectively like that is so that the workload doesn't cripple GPs, because if everybody suddenly was able to see everything, there would be an awful lot of work to be done going back through the record to check that there wasn't things in there that the patients shouldn't see. And there are some things, not very many. So one example would be someone's neighbour calls up to say they're worried about Mrs. X, that she's been behaving strangely, but they don't want Mrs. X to know that they've spoken to me. So I would have to not share that with the patient legally. But there's not very many things, but it is quite a time-consuming process to go back through the notes. So in England, it was supposed to happen yesterday. It didn't, because the British Medical Association has objected to the speed at which it's being rolled out. But I do think it is going to happen soon, that patients are going to, from a certain date onwards, they're just going to automatically see everything that's in their GP record. And that would include the free text entries that we type in whenever we're consulting, hospital letters, test results, medications, allergies, vaccinations, literally everything in the record from a certain point onwards, apart from just the little tasks that clinicians send between each other, as you know, little reminders and things like that. So I think in theory it's a really good thing. So just going back, the first question about the benefits, there's loads of benefits, and Kerry and Mary have covered most of the things I would have said. So people can prepare for their next appointment by having a read through what happened at the last one. People often don't remember everything that was talked about during consultations, so they can log in afterwards and remind themselves what was said, especially if it's quite a complicated plan. They can get access to their test results more quickly, so they don't have to wait in a telephone queue waiting to speak to reception to get their test results. It can improve patient safety because they might notice errors in their record. So maybe an allergy that's wrong, they can then let their GP know there's a problem in the record, so it can improve patient safety. It can improve communication between healthcare professionals. Someone can go to A&E, have their GP record on their phone and show it to the doctor in A&E, because they use different electronic systems. It can get people more engaged with their health, improve health literacy. So, there's loads and loads of benefits. And I could just very quickly cover some of the risks. So we've done research with patients and also with primary care staff as well. And the kind of things that primary care staff are worried about is there's four main categories. Workload. Will this increase our workload with lots of people calling up because they don't understand what they see, with queries? Safeguarding concerns, so things like being coerced into showing their record to an abusive partner, for example. This worry that patients are going to be upset by what they see in their record or not understand what's in the record. And the fourth sort of category of concerns that GPs have got is that it's got the potential to further widen health inequities. So people that are less digitally literate, less literate generally, don't speak English as a first language, maybe have specific sort of, visual impairment, dyslexia, that kind of thing, they're going to be disadvantaged by this. So, it's that argument that there's a really big group of people that would benefit from it. There's a small group of people that would not benefit from it, but that doesn't really mean we shouldn't do it, because it's going to still benefit a larger number. But we do need to think a bit about that group of people who would potentially not benefit. What can we do to make it better for them as well? So yeah, I'll stop there.
Thanks, Brian. It's remarkable that despite, I guess, the approach from NHS England to switch on a mechanism that, despite maybe the intentions of making life easier, that the number one concern is that it makes life harder for maybe either the providers or indeed the professionals. And that's something that I think we hear certainly in IPOSI a lot about, in terms of be careful what you wish for, because you don't understand maybe the consequences of certain types of approaches. And I think that that's something that we need to talk more about, because it tends to be a fear, and a fear of a fear leads to inaction, certainly. And as you say, even though currently in the NHS in England there is I guess a fear that's leading to inaction, but hopefully the time that it will take to actually resolve some of that fear will result in better policies and practices that will ensure that professionals are not overworked because of changes. So, and I certainly know from the GP conversations in Ireland that in terms of being currently overworked, I mean, it's just incredible what's currently being asked of GPs.
My experience from what's been happening, it's been going on now for over a year, and the really key issue in my mind regarding records access is this opt-in versus opt-out debate, because NHS England argue that it's been opt-in now for a few years, and it's not really working because patients aren't requesting it. Whenever they do request it, they don't always get access straight away. Whenever they do get access, they maybe only get access to limited sections of their notes. So they're saying the opt-in model is not working, so we should just give everybody access to everything. The flip side of that, so organizations like the BMA are saying that an opt-in model is better. And there's a really nice analogy. So the analogy is that records access is a medical intervention, and any medical intervention has its risks. So for example, if I was to prescribe a drug to somebody, there's always a slight risk they're going to have an allergic reaction to that drug if they've never had it before, and it could have a really serious implication. Potentially could kill them. But that doesn't stop me from prescribing someone who needs penicillin for the first time. I will still prescribe it. And Open Notes in the States, so there's the founder of Open Notes, Tom Del Banco, would argue that, so just because we think there's some potential negative consequences doesn't mean we shouldn't do it. And that's quite a clever argument, and I can see that angle. The opposite, the flip side of that argument is that we shouldn't be giving a patient a drug without explaining to them what the risks are first. And that is more like the opt-in model. So the opt-in model, you would check that a patient would understand that, for example, there is a risk they might see things that might upset them. There is a risk they might see test results before the doctors had a chance to discuss them. There's a risk that they could be coerced into showing the record to somebody else, or there's a risk that the wrong patient's information might go into their record. And the opt-in side of the debate would say that we should be having that discussion with people before we give them their record. So it's two very interesting sides. And I think that's one of the really key issues in record access. And that's what the battle is about at the minute in England.
Thanks, Brian. Some really, really useful analogies there. I'm going to move the conversation into what I guess the overall topic is about, and rights-based approaches to accessing health information. And I might ask Kevin O'Carroll from HICWA to maybe give us your perspective on what exactly we mean by rights-based approaches when we talk about this, and I might even have a follow-up question for you afterwards. But Kevin, please join the conversation.
Hi, Derek. Hello, everybody. Thanks. Yeah. Look, just building on this, we've previously surveyed people in relation to accessing their information, and 86% of people feel it is very important for them to access their own medical records, and also.
Sorry, Kevin, I believe we're just having a bit of an echo on the line. Is there, if maybe Shannon, or could we just maybe mute, make sure everybody else is muted? Thank you.
Yeah, everybody else is muted aside from Kevin. So Kevin, can you try again and maybe?
Is that any better?
No, there's still an echo.
Give me one sec. Let me get ahead. Give me one sec.
Okay.
Well, while Kevin's getting his headset, I might ask Ruth to come in. Just on that question about what we mean by rights-based approaches.
Well, from my point of view, a rights-based approach is very much it's almost like a conceptual thing, really, where you're giving people the framework up front. You're enabling people really to exercise their right to access information, and you put a much more pressure on the systems to allow that to happen. So if I kind of go to look at maybe Brian's discussions and whether you opt in and opt out, I would argue that when it's more of a rights-based lens that you're looking at, you're giving people it's an opt-out model that you're really looking at that point, where they're really being empowered to actually look at their information in the first instance and take charge of it. And that's a little bit, I think, closer to what Kerry and Mary have also been discussing, that element of giving people, the rights, giving them the means by which they would be able to exercise those rights as well. Whereas if it's legislation only, as opposed to sort of that it's recognized as a right, well, policies can change very, maybe even from one government to another, to the next government, and therefore legislation can change as a result. And what might have been possible in one piece of legislation might be changed in another. But I think it's much harder to change that legislation if the right is recognized up front. And the good news, I think, from our point of view, is that in reality, European Union has recognized access to personal data as a fundamental rights and freedom. So that framework is actually there already. And while it may not be explicit in the Irish constitution in terms of personal data, we as a country, Ireland as a country, is signed up to the European Charter. So the truth of the matter is actually part of our law already. So I think the actual, what I would call legal framework of it being a right exists already. And then it's really a question of what are the frameworks that you need in order to implement it. So I'm looking, and your second question is can people access their data at the moment? Well, in principle, they can. And many times, in practice you can, but it is definitely not always easy. And I know there are lots of suggestions. You obviously have GDPR, you do have freedom of information. These give you legislative rights to access your data, but there's always some sort of a process that you have to go through in order to get it. And it's not necessarily contemporaneous. So it's not like it's always switched on information. And there's no doubt that you can see that I think if you really want to exercise a right, the always switched on information is the type of system that will allow you exercise that right more effectively. And I think you can always opt out. I think I tend to agree with everyone. The benefits associated with having access to the information outweigh the disadvantages. And I do think that there are sort of safety mechanisms that you can put in place in order to protect the difficulties that one might face as well. But I do think it should be, you should have access to your data.
Thanks, Ruth.
Can I say something very quickly? It was
Sure,
while you were
Mary.
talking about it, I'm thinking, okay, so this, I'm going to see the doctor, it's my body or my mind, something maybe I'm worried about or isn't working. I go, it's almost like even with the car, you take it somewhere, you want an opinion, you want it fixed, or you want an opinion about it. And then it really is your right to know, well, what happened? What is the result of all of this? I'm thinking if you take your body somewhere, you get it looked at more closely, there is a result. And if you've gone to the effort of going there to get that result, I think you should have easy access to it. I also think there's an upside in people knowing about what's happening on the inside or whatever problem they've had to understand it more. You're going to have empowered people. You're going to have people take more responsibility for their care, for their health care and for their whole lifestyle. So I just see a lot of positives. I know they're in the negatives, but that just came to me when you were talking. If you take it like your car or any other object, you want to make sure it's working properly, and you might need to know the full detail of everything. We're not asking to interpret the MRI, but you should have some idea as to what's on it.
Thanks, Mary. Really valuable. I might ask Kevin if you're. Yeah, it seems to be working now, Kevin. So Ruth, I think, gave a really nice context there in terms of the fact that the EU believes that this is a fundamental right. It's exercising that right in Ireland in a way that ensures that it is a user-friendly process. I think is where a lot of patient members of IPOSI certainly find there's a lot of challenges and steps. But obviously, HIQA has been promoting rights-based approaches across a number of its areas. So how does this fit with what you have been doing?
We would traditionally have actually had rights-based approach.
Sorry, Kevin. There's still an echo. Can I just ask, are you logged into the meeting from two different devices, or are you just on one?
One.
Okay.
Sometimes if you just log off and log back in again, it fixes it.
Yeah, that might be the best.
Okay, well, hopefully we'll get Kevin back before the end of the call. So there's lots of things in the chat, and I'm conscious as well that one of the things to exercise that right is through obviously an online portal, and there's been many examples of portals being created both in public settings but also by private providers to various degrees and extent in terms of what you can and cannot see through portals. And I'm conscious as well that Orla Gogarty is there from St. Patrick's Mental Health Services, and that's an example of a I guess a private provider that has recognised the value of not only a portal, but to design that portal with the service users of the service. I don't know, Orla, do you want to maybe unmute yourself and tell us a bit about the value that portal has brought to your own services?
Hi, Derek. Can you hear me?
Yes, loud and clear.
Yeah. So I just to point out that I have a few colleagues on the call. Frankie Fitzmaurice, who's really been the implementation lead on the portal, and Siobhan Fitzharris, who's our service user engagement coordinator, who's really led out on the service user advisory, which we work with to co-design the portal. So we have an electronic health record, so we have data to share. That's the first thing to say, because if you don't have data to share, the portal is just it's empty. So we realized very early on in the roadmap that we needed to be focused on empowering service users to have access to their own information, so that they can use it to either keep aligned to their treatment, or to empower them during the recovery. And mental health really has an emphasis on I suppose, service users' participation in their own recovery, because it's their lives and it's their journey. When COVID happened, we had gone out to market, we procured a standalone portal, but we decided to deploy it early because COVID meant that many of our day patient outpatients couldn't come to site, and we really didn't want them to come to site in masses, because we want to protect their own health and the health of those that were inpatients at the time. So we started off gently by sharing information around appointments, and we have a roadmap. But at the moment, we have a very exciting project which sees our inpatients getting a copy of their care plan, information around their key worker, access to information about or filling out forms around their expectations of care. But I think I'll hand over to Frankie just to give you a little bit more detail on it. But and maybe Siobhan can talk to you about the service users' involvement in the advisory process. Sorry, Frankie, just 1 second if you can mute. So and then I'm really excited that you have this session, because it really, if you come from a rights-based approach, it's not rocket science. You just have to do it, and it's the right thing to do. However, I would say that you can't just pull a lever. Even though we have an EHR, you can't just pull a lever and release all the data. It has to be meaningful data, it has to be relevant data, because you could flood both clinicians and service users with that data flow, and it's not going to be of value. So it's really, that's where it comes back to the service users' involvement, finding out what's of value. So I'm going to hand over to Frankie and tell you a little bit more about the detail of the project, and don't want to take up too much time, but yeah.
Hello, I'm Frankie. So as Orla has spoken to, our portal, service user portal, went live during COVID. It has been a slow path in terms of ensuring that we had the service user engagement and their inputs into key information that would be of value. We had various consultation forums outside and wider than just the advisory group that we work with on a regular monthly basis. Pilot project we're running at the moment is around very much a two-way communication. So not only are we enabling sharing of information to the portal for the service users, as Orla mentioned, the weekly updates to care plans after there's been review with the key workers and the multidisciplinary team engaging with the service user, but also with the information that the service user is completing in the portal, coming back into the electronic care record to inform the care planning process in the information such as their expectations for their care and treatment plan and their views and opinions on a weekly basis contributing to their care plan. So that stage of the roadmap has really, we've just started that pilot about a month now, and the feedback we're getting from service users is really interesting, and really interesting around the conversations we've had with some of the service users that are using the portal in that way, around feeling empowered to ask questions, and to not necessarily challenge, but maybe have more discussion about their care plan, and also just being able to retain information on a conversation basis, as opposed now they can actually look back and have time to contemplate on some of the conversations they might have had with clinicians, and feel that they're more informed to have further conversations about their care and treatment plan. We do use it in our therapeutic programs, and a lot of that is around sharing assessment forms that contribute to the pathway through the care programs as well. And we have the electronic appointment management system, which is triggered through our electronic health record. It also enables service users to attend remotely, so they get their video links for their remote consultations in their portal.
Thanks, Frankie. Sorry, I don't mean to interrupt you.
No, sorry, I apologize. I could talk all day about it.
Thank you for that insight, and it's wonderful to see that there's examples out there where like those benefits are being realized. I think the major question from a national perspective is how that works then across different settings, be they public or private? And how do you ensure that it is a single portal? I think Anthony Staines is on the chat emphasizing that. So I do know from our work on the at the national level that there are plans for a summary care record, and that the portal view onto that summary care record would be different for a clinical view and a patient view, or for lack of two better terms. And that's currently the plan. I think from an IPOSI perspective is like, we would like both views to be informed by both sides, and that it wouldn't always be this, well, you can see this, but I can't. There's going to be certain times where that's going to be probably necessary, but at the same time, you can design it in Ireland, and we have an opportunity to design it and co-design it with all stakeholders. Kevin, you and I have worked on portals for many years, so we'll have one final go at trying to get your mic working.
Testing 1, 2, 3.
Yes, finally.
Good, that's a relief. Yeah, look, HICWA's done quite a bit of work in this space historically on shared care records and portals, and we've even previously gone out and done surveys on people with people in relation to accessing information and being able to know who has accessed their information, and very, very positive comments on it. We started to look at a patient portal project this year, which would make, trying to answer some of the questions on what we do at a national level around the patient portal. And when talking to our international colleagues, it was a lot about engagement with both the public and engagement with health and social care professionals. And we need to start that journey. So we have decided to undertake, building on the previous public engagement that we did, to undertake a national engagement, which we're currently developing and specifying. We're going to go out and look again and go into more detail with the public on the information that they want to access in more detail. What do they see the benefits and challenges for themselves are, and what do they see the benefits and challenges for health and social care professionals? We're also going to build it on and look towards not just accessing information, but care being provided digitally. In parallel, we're going to actually go and engage with the health and social care professionals on a similar survey to try and understand their attitudes and opinions to sharing information, what risks they see, what challenges they see, and their interaction with people digitally. So that's a space we're moving into. A lot, we would see that, for any major project of that space, a lot of engagement needs to happen. And even like from what Brian was mentioning in the what's happening in the UK with the NHS app, we need to bring the health and social care professionals down the journey as well. So I see our surveys starting that journey too.
Thanks, Kevin. I want to bring back in Kerry at this point. So it was something you mentioned at the beginning, Kerry, in terms of, I think it was basically the transition between, say, the current processes, whether it's through FOI or GDPR, for access to your record, and a digital, a portal based, and the risk that's often involved in terms of that transition, and also the risk that's involved in terms of transitioning people from a predominantly paper-based system to a digital-based system, and what levels of expectations there might be or prior experience. Do you want to maybe give us some thoughts there?
I was talking about that it's a process that people have to go through, and a lot of it's not just about the technology that's involved, it's about the mindset that's involved, and bringing people into a new way of being. And I noticed just in the chat box, there's a lot of people talking about the language that's used, and how that can be quite off-putting in the patient when you read doctor speak, and that you maybe have to have a sort of a tougher skin when you read that type of thing. But I was also thinking about the point that Brian had made about the digital divide. And he talked a little bit about maybe people with dyslexia having more issues with digital portals. But of course, with dyslexia or any sort of issue with learning disabilities, written records on print also pose an issue. Though obviously when you add in then accessing technology, that makes it more difficult. I was thinking more of the digital divide in terms of actually accessing technology and then needing to have maybe a printer or needing to use apps and needing to have smartphones of that sort of standard to be able to use this sort of technology. And I was thinking more on a sort of an income and class basis, that we need to be careful about that sort of divide and equality issue. And Brian had made the point in the UK that they're finding that, yes, this is going to benefit a large group in society, but there's going to be people whose maybe English isn't their first language, or who maybe have more literacy issues as well, and issues accessing and using technology. And I think we do have to be mindful of that, because health literacy is already an issue in Ireland. And I know that NALA, who I used to work for, do a tremendous amount of work around that. And I'd imagine, I don't know if IPOSI already work with them, but I imagine they would have issues around health records and access to health records. And that, I imagine, should be part of the health or the rights-based discussion to health records, that how are we going to do that in a way that ensures that everybody gets equal access and maintains equal access. And it's a big ask, and I'm not sure how we do it, but it's just something to think of, that while we all need the equal access, it's not equally easy for everyone to get that access and maintain that access to it. Because sometimes you, even though you want the app and you want to be able to read it, sort of Luddites like me still want to print it out and still want the printed copy with me. And not all of us have home printers, and not all of us have access to that sort of technology as well. So it's about, I suppose, balancing all these needs and making sure whatever we do, don't make that digital divide wider.
Thank you, Kerry. And Brian very helpfully has put in some examples in the NHS England for trying at least to address some of those issues. Before I go to Mary, I might just turn to Brian quickly. So you mentioned the Open Notes initiative which is predominantly in the US, but I know is spreading to other countries now, and that's about getting full access straight off the bat. And you know, it strikes me that this conversation is reflective of maybe a conversation that's been happening in parallel around open disclosure in Ireland. And when we devise national level policies and try then to implement them in certain instances, I guess the variability of implementation tends to be somewhat less than what was maybe originally desired, and ends up becoming kind of creating a counter argument both politically and publicly. That sometimes is not helpful to the full implementation of the policy. So I'm just wondering, in terms of that argument of full versus restricted, has there been any kind of obvious risks that have maybe highlighted originally before Open Notes began that were realized when Open Notes was implemented in terms of that full access? Has there been any research or anything done around that?
So speaking to the Open Notes team from the States and also from other European countries, I was at a conference in Sweden a couple of weeks ago. The general message, no matter where this happens, clinicians seem to be expressing similar concerns, but certainly the message from the States was that those concerns largely were not realized. And whenever records access was switched on or Open Notes was switched on in the States, there's some of the clinicians apparently said they thought it hadn't been turned on. They were expecting to get a deluge of lots of queries from patients, and it didn't really happen. So it was described as like almost a bit of a non-event. That leading up to it, they'd been all very anxious and worried about the implications, but when it actually happened, it wasn't as big a problem as everybody imagined, and it was actually a bit of a kind of anticlimax in some ways for, you know, from clinicians' point of view. I think the issue of whether or not you've got two different views, I think that personally my preference would be that it would be that patients can see almost everything. And I think there are going to be some limited situations whenever certain patients would be put at risk. And I think there's Ruth will probably be able to help me here, but I imagine there will be legal guidance on when the GDPR law wouldn't give someone the right to access the record, but not very many occasions. So the guidance we've got is that if you think that a patient viewing something in their record poses a significant risk of harm, that you would be justified from redacting that from the record. And a really good example would be someone who you know is in a coercive relationship, who's recently had a termination, and you're worried that that abusive partner doesn't know about that you would be justified in that case for redacting that from the record. So that's just, you know, there's like lots, it's a kind of a continuum. You've either got patients and clinicians having access to exactly the same information at one end of the continuum, and then at the other end of the continuum, you've got patients just having access to, you know, really bullet point summary of just a list of conditions, a list of medicines, and a list of appointment dates, you know. And I think the reality will always lie somewhere in between those two whenever it's implemented, because there's always going to be some things in the record that we might not be able to share with patients for either legal or safety reasons.
Well, I would concur with that, Derek. It's very much the duty of care on the part of the GP, which would trump something in GDPR. And we all know that whatever right you may have to access, it's always counterbalanced by other rights. They're never absolute, but they tend to be, as you say, kind of quite defined by duties of care to the person that you do no harm, because that might be the overriding right that someone has, that you do no harm in the first instance. And that would be what I would say in terms of those competing rights. My own feeling would be is it's quite hard to argue why you would have a subset, really, or a summary version of medical records, when in fact you're really generally entitled to everything, and it's just a different process that you have to go through. This is merely a means by which those records are being made available to you. So legally, you're entitled to those records anyway, as I say, subject to that, maybe that duty of care and so on. And one of the things that I think that we might need to do, I'm quite interested, because Brian has obviously indicated that in the UK, it's all prospective records going forward. And I think that that's a good idea, because there's no question that historically people didn't write, and you can see it in the chat. There's a lot of language used that is less than maybe appropriate or easy to misinterpret and so on. And I do think that there's going to be a need to train up clinicians and other people who are going to be writing into the records on appropriate use of language. Not that they would dumb down the medical statement that they're making, but that they are using appropriate language around that, so that it's not seen that it has less negative overtones perhaps, and so on. And I look to the analogy when I used to be in the university system, and of course freedom of information was introduced at that time, and every time you wrote an email, and it became part of your life. Every time you write an email, you had to actually think, someone might ask for access to this email, somebody might read it. Do I mind that this email will be public? And it just means that you have to filter your language appropriately. Not that you don't say what you want to mean, but that you just manage how you say it. And I think those are things that will actually have to become part of medical training going forward.
Great points, Ruth. I'm trying to capture some of the questions that are coming through in the chat in the form of a kind of a question, a general question. And there seems to be a pattern about the quality of data that currently exists in the record, and kind of speaks to a point that Orla Gogarty made about, well, if you don't have data to begin with, then what's the point of giving people access to it? And I'm just wondering, Mary, in terms of your own work, in terms of within the clinic, or indeed in the work in terms of development of a registry, have you come across quality issues?
All the time. That's why I'm so for people having to have access, because there are serious quality issues. And as I said, clinical risk, because patients don't have the data, and they're asked by another professional for it, because that professional can't get it from anybody except perhaps the person, and that person doesn't know about it. So there are quality issues. And I must say, I agree so much with what Ruth and Brian have just said as well. I mean, we're in that space now. It's just a question of the how. If you look at it, the patient has the right. It is the patient's information. I personally do not think that it should be shortened in any way. I mean, Dr. Google is the chief doctor in this country. Every patient I've gone out around this disease and other diseases, and they're all consulting Dr. Google. So they get over the language barrier. They get over there. There's a danger there, because then they can go down and misunderstand perhaps some of the notes and think they're a lot worse than they really are. So yes, but this will all lead to empowering patients and empowering the doctors and straightening everything out. We're in that era. Everything is going digital. This has to move as well. So it's protecting and it's putting the right information in the right way so that the patient can have it in that format and have the supports that the patient needs afterwards to be able to interpret, understand, and use that information. So for me, there's a lot of work to be done. There's a huge opportunity there for people and healthcare professionals to develop more programs and empowering, because you need to empower the patient, and you need to reduce the risk of what's happening actually, because right now there are huge big gaps, and the gaps are in communication and around that information. So this will streamline it all. For me, we're moving there.
Thanks, Mary. I might bring in Kevin. I'm just conscious of time, and I'm giving everybody 2 goes. So Kevin, in terms of what you've heard to date, and maybe the work of HIQA, and in terms of I think, certainly from my experience, it's all very well taking rights-based approaches, but if the implementation of such just leaves a lot to be desired, what do you think are the main actions that we can do to adopt this in Ireland?
We need to look towards, even with data quality, okay, you need to actually look towards as well potential information sources. If you're trying to get information out across different care settings, from primary care, community care, acute care, we need to look at the quality of data that's coming through into and can be given access to patients. I do believe, building on what Mary was saying there, giving people access to their information can actually empower them and can be a great educational tool. And people do upscale on the medical terminology. Ourselves, we're going down this road of engaging with people and the health and social care professionals to undertake then a recommendations project to actually look at the implementation side of it. So we're trying to understand people's actions and activity or attitudes before we get into the implementation. There are small things we've learned already when you go through prospective access. Quite a few of the countries internationally start with that, even in the Nordics. Quite often those who are very far advanced started with more prospective access than historical access to it. So I think there are activities that we can be doing ourselves. We're undertaking this national engagement to understand where people want actually the digital care to go for them.
Thanks, Kevin. And I think that's a good way of ending it. And if I might add just a tuppence at the end, we did see our incoming Taoiseach talking on national TV about how we can do this. And so if there's political will behind that comment, I think that would certainly help things move along. So that's something that IPOSI will be looking to call out on. So it's just gone 1 minute past 2. It's been a fabulous discussion. I think this is certainly not the end of these ones. And I would just like to thank everybody for joining us today. I would really like to thank all of our speakers. I think your input and your insights has been fantastic. There is a poll that's just being there for anybody who wishes to complete it. If you have 2 or 3 minutes to just tell us a little bit about what your own opinion about this topic is, it would certainly inform IPOSI's positions and responses to today's event. I would definitely like to thank both Laura Kavanagh and Shannon Karpinski in the IPOSI office for facilitating this. Despite some of the technical issues, I think we've gotten through. So we'll leave the poll active there, and if people wish to finish it at their leisure, we'll keep the call open. But until the next time, and please feel free to follow us on Twitter. There's lots of good collateral being shared on Twitter and good notices to a lot of the things that have been discussed here and more. On this topic of access to health information. So, and we will certainly be sharing some of the links and some of the suggestions that have been put in today's discussion, and indeed through the chat, which has been flying away in the background there. So yes, please. And I think, yeah, just thank you everybody, and we'll see you all soon.